Good afternoon. Welcome back to UCSF Department of Medicine Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. Welcome, as usual, to our live audience from the department and from our other colleagues at UCSF and throughout the UCSF Health Network. As has become our practice, we'll post this tonight on YouTube, probably about 7:30 Pacific, and I will tweet that out, the address, as well as a brief summary when we do that. And again, our previous parts of the series have now been viewed over 1 million times. The ground rules for the audience are here. Put your Zoom window in full screen mode. If you have questions, type them into the Q&A box. We'll get to as many as we can. My colleague Quinny Chang is monitoring that, and we'll go from there. So as unfortunately we have predicted for the last month or so, we're now in the early to middle stages of a third surge. We'll hear more about that soon. One that may prove to be the most dangerous one of all. While a few weeks ago it seemed fairly localized to the Midwest part of the country, it now seems to be hitting much or most of the country, with California being, at least so far, a notable exception. And of course, all of this is playing out against the background of a highly contentious, if you haven't heard, a highly contentious presidential election in precisely 12 days. In today's Grand Rounds, we'll start with the George Rutherford updated on the state of the pandemic. He'll talk something about the surge in the United States, and also a little bit on what is happening in Europe, which is even worse. One of the states that is hardest hit is Wisconsin, and we'll hear from two clinical leaders at the University of Wisconsin who will give us a report from the front. There's a lot of vaccine news that all of us have been hearing. Much of it has been hopeful, but even if we have an approvable vaccine in the next few months, it'll take several months after that before we see a material change in the pace of the pandemic. So until then, and probably even after then, all of us several times a day have to make really hard decisions about how to balance our desire to live our lives with our tolerance for risk from COVID. At the same time, policymakers have to make similar trade-offs at scale and in a contentious and highly partisan political environment. One of the world's experts on managing and balancing risks in the face of infectious threats is Julia Marcus, who will speak to us about these complex and really interesting issues. That will be the last segment, and it will go from about 12:40 till we finish at about 1:15 or so. So very interesting, diverse program today. I look forward to it, and we will begin with George Rutherford, who by now is well known to all of you. He's professor of our department of Epidemiology and Biostatistics, directs the Prevention and Public Health Group, and has been teaching us all for the last 6 months about how to think about a pandemic. So George, you are on.
Thank you, Bob. So I wanted to start off with a little review of what's going on worldwide. If we ever slowed down our incident cases in the United States, India would surpass us. It's kind of creeping up over time, but there's still 800,000 cases fewer in India that have been reported than in the US. Brazil is kind of stabilized out at a solid third. But I want you to realize, not only in Europe, but also in South America, how devastating this has been. And of the top 10 countries, Brazil, Argentina, and Colombia, and Peru are in South America, plus Mexico's 10th. So this is truly a universal or worldwide disease. Europe, as you can see down in the bottom right-hand panel, is having a large surge. Ireland and Wales have already moved to lock down their economies, and it seems like others are not going to be far behind. And you can see up here on the upper panel the data by continent, where Asia really refers to India. The Americas are quite diffuse, as you can see, and Europe is spread out pretty much across Western and Central Europe. Next one, please. In the United States, we've had 8.4 million, almost 8.4 million cases reported. As of this morning, we're clearly in a surge. Cases have increased by more than 100% since their lowest point in September. We're currently running about 60,000 cases per day, and had 62,485 reported yesterday. So you can see the third wave is clearly here. This is no longer theoretical. We're right in the middle of it. The next one, please. And this gives you an idea of where cases are occurring across the country with this sort of preponderance, not only in the upper Midwest. You can see Milwaukee, you can see Wisconsin, Minnesota, Illinois, Iowa, Nebraska, heavily impacted, but also scattered through the Great Plains states like North Dakota and South Dakota and into Montana, Wyoming, Utah, and Idaho. The cases with the greatest per capita increases over the last 7 days are North Dakota, South Dakota, Montana, Wisconsin, as we'll hear, Nebraska, Idaho, Wyoming, Utah, and Iowa. But the greatest absolute case counts are in Texas, Illinois, part of the upper Midwestern cluster, California, Florida, and Wisconsin, also part of the upper Midwestern cluster. And the states with low and stable rates are Delaware, Maryland, California, New York, Oregon, Hawaii, Maine, and Vermont. So we have California, Oregon, and Hawaii on the west, and some New England states and mid-Atlantic states on the east, and everybody else is in full-on pandemic mode. The next one, please. Just so you've seen this, this is these are IHME projections of cases, and the middle dashed line are the number of cases that are predicted by day out through February 1st, 2021. And that's going to be, the prediction is that it's going to be somewhere around 250,000 cases per day. That's substantially more than there are now. There are about 60,000 right now. So we can expect to see a tripling, and hopefully that'll be spread out sufficiently across the country that we're not going to have the kind of ICU burdens that we saw in the past. The lower green line is if everybody were to wear masks. And so you can see the big differences that come with wearing masks. You also see here quite clearly what the third wave will likely look like, and then could look like if everything gets truly out of hand. The next one, please. Here in California, we've had 887,000 cases and 17,191 deaths. There were 3,000 more cases on October 21st, and that's about what we're averaging. And 125 deaths reported on October 21st, which is higher than we're averaging. We're averaging right around 60 to 70 deaths, but you can see how choppy it is. We are in a plateau. There's no evidence of a third wave yet. Next time I talk to you in a few weeks, there may be, but for now there's not, and that's something to be. I kind of have the feeling we're teetering at the precipice, and we need to be absolutely positively clear that we need to do everything we can to avoid infection. Next one, please. Here in California, again, these are states with the most cases per capita. Counties with the most cases per capita. You can see Shasta and Tehama, which we've discussed before, which have institutional outbreaks. Sonoma, which has, it's largely in the northern part of the county. It's probably tied to agricultural work and the seasonal harvest. And then San Bernardino and then poor Imperial continues to have lots and lots of cases. We, however, as a state are at 2.6 positive rate. I heard the other day that Wisconsin was at 20%. And I'd like to hear the latest from the field on that. And our bed usage, both ICU and overall, is the lowest it's been since mid-April. The next one, please. And here in the Bay Area, we've had 113,000 cases roughly and 1,704 deaths. We are actually in a decline here. Cases are continuing to fall, as thankfully our deaths. The R sub E's for every county except Solano are below 1, and you can see these different colors here under cases per 10,000. Cases per 100,000 per day, and the ones in and this will tell you where the tiers are that we're in, and the tiers are all pretty good across the board except for Sonoma, which is in the worst tier, most restrictive tier, and Solano, which is in the second most restrictive tier. The next one, please. Here in San Francisco, just to show you the R sub E, we're at 0.94. We've done better, we've done worse, but it's all pretty good. Now, with 0.94, as you realize, will eventually extinguish transmission, but that's a long way off. And there's a lot of literature, which I may come and talk to you about, which I may talk to you about next time, about super spreading, that says that the R sub E, while important, may not be as important as a diffusion coefficient K, which talks about the number of people who cause more than one case. A lot of people don't transmit to anyone. Some people transmit to one, and some people transmit to a lot. And the R sub B is really an average across that. So it's a little bit, it hides big differences. The next one, please. Now, why is California doing better? This is looking at mask wearing. And I think there's a greater acceptance of personal protective measures, wearing masks, distancing, those kinds of things. I think that we've had a slower and steadier reopening, especially compared to a place like Florida. We have done a pretty good job of controlling institutional outbreaks, especially in nursing homes of late. We have a mature contact tracing, quarantine, and isolation system that's really up and quite functioning. Luckily, there's declining prevalence in Baja California, which had been a big source of cases in Southern California. And then the question always rears itself about warmer weather. I'd like to hear how warm it is in Madison today. But it's, as people start to come inside, all bets are off, and we have to be really careful at that point in time. The next one, please. And this just gives you the looking at by state, the dots are states. The y-axis is the proportion of people wearing masks most or all of the time, and the x-axis is the new cases per 100,000 over a 7-day period. California's clustered up on this cluster way up here in the upper left-hand corner. But as mask wearing goes down, case counts go up. The next one, please. Now, deaths. I wanted to spend a little bit of time on deaths. Today, there have been 222,000 deaths in the United States. States with the greatest per capita increase in deaths in the last 7 days are the same ones we've been talking about: North Dakota, Montana, South Dakota, Missouri, Kansas, Arkansas, then Florida, Iowa, Mississippi, and Indiana. And the cases with the greatest number of deaths are Florida, Texas, California, Illinois, Missouri, Georgia, Indiana, North Carolina, Michigan, and Wisconsin. And as you can see, we haven't really seen a third wave of deaths yet, although there's this kind of tiny suggestion right down at the far right-hand end of this curve. Well, that remains to be seen. The next one, please. I show you this because you'll hear this if you listen to the debates tonight. These numbers get thrown around a lot. The current IHME projections are to have 389,000 cumulative deaths in the United States by February 1st. Again, we're currently at 222,000. If everybody were to wear masks, it would be around 315,000. If everybody goes the way of Florida, it would be more like 483,000. So when people talk about it, if you wear a mask, you can avoid 75,000 deaths. These are the numbers they're talking about. And I would point out that by close to somewhere between February and March, we'll surpass the US mortality from all causes in World War II. The next one, please. Now, the CDC's published some interesting data about excess mortality in the US, and this is not necessarily COVID related, but the supposition is that it's somehow distantly related to COVID, if at all, if not directly caused by COVID. The estimates are that there have been almost 300,000 excess deaths since mid-March in the United States. 66% of those can be directly attributed to COVID. The next one, please. And if you look at the excess deaths, this gives you an idea kind of what we're talking about here. These are all the ones, the total number above average. This gives you both cases excluding COVID in the darker blue, both with the upper bound and the mid-range value, and then the lighter blue is the COVID death. So the point is that about a third of these excess deaths are not due to have not been directly ascribed to COVID. Some of these may be just miscoded. Some of them may have been, without benefit of kind of clear diagnosis at the time of death, and some of them may have been precipitated by COVID, like myocardial infarctions or pulmonary deaths. The next one, please. And of these excess deaths, they are most pronounced among 25 to 44-year-olds. This is looking at the percentage difference between current year, between 2020 and an average from 2015 to 2019. They're most pronounced in 25 to 44-year-olds and most pronounced in the Latinx population. And I left off a couple of panels here, but if you want to go back, there's the reference to see older ages and other races. And the next one, please. So I was asked by my department to come up with some concrete advice for Halloween. These are a couple of great ideas. I figured this was timely. The Chronicle has all sorts of cool ideas. CDC has its usual turgid advice. But the bottom line is be careful what you do. Keep social distancing, wear masks, avoid crowds, especially indoors. And when you're done for the evening, brush your teeth. And with that dental public health message, I have done and happy to answer questions. Thank you.
Thank you, George. And fair to put a fine point on it, a Halloween mask is not a good enough mask for the purpose you're talking about.
Yeah, unless you're playing, unless you're playing an ICU worker in a PAPR. Yeah.
Right.
That's right.
Okay, a couple of questions for you, and then we will turn it over to our colleagues from Wisconsin. The 25 to 44-year-old excess deaths, I find that surprising. Are they COVID deaths or non-COVID deaths, and how do you explain that?
They didn't break them down, but it's because the death rate's so low in this population, basically. So that you see these. So when you start seeing COVID deaths, it's amplified. This is the proportion. This is the percentage difference between the prior 5 years and the current year.
Got it. Africa seems like a notable exception to the cases. Yeah. What's going on?
Well, South Africa's had a fairly large epidemic. South Africa is about 11th or 12th on the worldwide list, but they have a big national virology service and have the capacity for diagnosing things. We have people in permanent staff in both Kenya and Tanzania. The word from Kenya is that everybody's kind of slowly going back to work. The word from Tanzania is that there's nothing going on. There are some fairly prominent deaths in Tanzania. And in cabinet secretaries and the cabinet ministers and stuff, but even the CDC offices thinks that it's kind of all over. So there may be something about tropical climates and UV radiation and whatever, but it just doesn't seem to be happening at any great extent.
Yet it's happening in India and other places with some tropical climates. It sounds like a fair amount of hand waving.
India doesn't cross the equator.
Oh, okay. Got it. Maybe final question for you. So San Francisco is opening back up. I guess we're on the lowest alert status.
Yeah.
Sounds like it makes sense given what we're seeing in San Francisco, but everything's connected to everything and airplanes are getting busier and the rest of the country is surging. Are we going too fast given what's happening in other places and how interconnected we are?
Well, the health departments kind of put the brakes on this, right? They like to because the local health department can superimpose additional restrictions on top of what the state says. They can't be less restrictive, but they can be more restrictive. So the health department has been trying to keep it slightly more restrictive, and go even more slowly and more steadily forward. I agree. I think that as airplane flights start to pick back up and people start to travel here, I think that we're going to potentially have problems. Yeah. Right now, I don't see any evidence of it at all. And I look at this stuff very closely every day. And even Los Angeles has actually turned the corner and is starting to go down. And what we're really seeing are institutional outbreaks in a handful of counties, and then some residual transmission in agricultural workers in some of the agricultural counties that are coming in late to the harvest. But we'll have to see, and it's certainly not over, and it won't be over until it's over.
Yeah, it's just hard to believe if it really is surging almost everywhere,
But not Oregon and not Baja California. Right?
Yeah. Okay. Great. Well, thank you. We'll bring you back in a little bit after we hear from our folks from Wisconsin. So let's move on. So these are two colleagues from the University of Wisconsin. One is my old friend Ann Sheehy, who is Associate Professor of Medicine and Chief of the Division of Hospital Medicine at the University of Wisconsin in Madison, and helping to lead their hospital ward response to the COVID surge that they're beginning to see there. And thank you for joining us. And helping to lead the ICU response at Wisconsin is Andrew Braun, who's Assistant Professor of Medicine and directs Wisconsin's Adult Cystic Fibrosis Clinic. But most importantly, he was a UCSF internal medicine resident from 2005 to 2008, and then was a hospitalist on our cardiology service for a year or so, did his pulmonary critical care fellowship at Hopkins, and then returned to Wisconsin, where he was trained in college and medical school. So thank you both for joining us. And let me just start by asking both of you to describe the scene there. What does it feel like at your hospital today, and how is it different than it might have been, let's say, a month ago? Ann, why don't you start?
Well, thank you very much for having us. I think for us at Wisconsin, this is by far the largest surge we've seen in our state. I think we were very fortunate in the spring. We were prepared for a larger surge, but really, fortunately, did not see that in our hospital. I think right now our volumes are about twice our peak that we had in the spring, and our state statistics indicate that that will likely grow. I think from our group's perspective, I am grateful for having a very resilient, mission-driven hospital medicine group that I work with. We've got great nurses, great respiratory therapists, great colleagues. And so I think the teamwork atmosphere is very high, but it is certainly a challenging time.
Okay. And can you have a sense of the numbers, like how big is the hospital and how many COVID patients do you have in the house right now?
So our hospital has a total of 592 beds, including our attached children's hospital, and our cases are just above 40 right now. So certainly not as big as other hospitals have been, but for us, it's been a major change.
So a month or two ago would have been 5 or 10. Is that
5 or 10? Yep, exactly.
Got it. All right, Andrew, what are you seeing, and particularly in the ICU?
Yeah, so our ICU census has lagged always our hospitalist census. And so in the last 2 weeks, we've seen the majority of the surge in hospital medicine. Our ICU census today is 10 patients, and we are adding about 2 to 3 per day in the last couple of days. So we are preparing to go live with a second ICU team very soon.
Okay. And is this surprising? Tell us a little bit about the behavior in Wisconsin and the political climate in terms of what the rules have been around masking and distancing and restaurants and the usual, and then sort of how people have dealt with it. As you walk around the streets of Madison, have you seen people wearing masks, not wearing masks, or what has that felt like up until, let's say, until the last couple of weeks? And
yeah, we actually here in Madison and in our Dane County put in a mask mandate very early on back in the spring. And so it is very unusual within our city to see anyone outside not wearing a mask. However, in the surrounding communities, it's definitely been less applied. We've had a state mask mandate, and actually just recently the governor did decrease bars and restaurants back down to 25%, but there's really just been differing enforcement of that statewide. And there's also been differing communication between our legislature, our executive branch. And so I think the messages to the publics are also can be confused, and that may be also making a challenge to really optimize all those standard public health policies that we should all be taking.
Yeah, I mean, it's we've seen a lot of the pushback in states like Michigan. Has that been true in Wisconsin too, where it's been a contentious issue, and you can tell what team people are on and politically by whether they're following the rules? Is that the general feeling in the state?
Yes, I think unfortunately that is true. I think, I think we as physicians, politics don't have any role in patient care, and we've been begging for a really consistent public health mandate. We've seen many of our governor's executive orders in this public health emergency challenged in the courts. And I think that's been very difficult to gain a consistent message for the public. And so I think politics has certainly played a role and really has hindered our efforts to have a consistent message of what to do to get the virus under control.
Yeah, and for the people that don't know it, Madison is a very different, probably political environment than the rest of the state. My older son went to Ann Arbor, and as he sometimes says, 10 square miles surrounded by reality. So these are, I'm sure, different political ecosystems in Madison as well. Tell us about the University of Wisconsin, a huge, probably 25, 30,000 students and all that. Do you know if they're back in class and how they are managing this in the middle of a surge?
Yes, so I think I give our chancellor a lot of credit for her plan starting in the pandemic. Unfortunately, we've had some bumps along the way. Our classes for campus were a combination of online and in person. Unfortunately, in early September, we had a huge outbreak on campus, shutting down 2 of our dorms. And I think over half of our sororities and fraternities were under quarantine. Classes were made completely remote for 2 weeks and then returned at the end of September. And things have been better since that time, but our number of cases on campus, we've had over 3,000 students that have been infected with COVID-19 out of a population of about 44,000 students total. That rate has markedly decreased, but we had a 7-day rolling average positivity rate over 10% for some time. I think our highest daily test positivity rate was about 33% back in September.
That of the students, or that's of the entire University of Wisconsin kind of community?
That's the student population with the faculty as well.
Wow.
And what Dr. Rutherford had said earlier, I mean, really the last 7 days, we've had a statewide positivity rate of between 18 and 20%.
Wow.
And so we passed 100,000 total cases about 4 weeks ago in the state of Wisconsin, and we're very close to nearing 200,000 just within the last 4 weeks. And our daily rate is now somewhere between 4,000 and 5,000.
How much testing is going on for the students? Are they in a sort of regimen where you're trying to test them twice a week? And if so, what are the logistics of doing that with 45,000 students?
Yeah, so a big task, but I think this was one of the efforts that was upfront, a really strong one. All residents of dorms got biweekly testing and continue to have that. Free testing is available to any student or faculty, and that is ongoing. In addition, our campus kind of randomly tests cohorts, volunteer cohorts, to try to detect outbreaks early. So I think all of the testing protocols have been very robust. It's just it's difficult to have college students come back to campus. I think when I think that fatigue that all of us feel in the setting of COVID, and then you have young students. I have a college age student myself, and it's difficult. So I think that's what we're seeing.
Yeah. Talk about the fatigue that you and your colleagues are feeling. How does this feel getting the surge now? It sounds like you're probably at the early stages of it. It's going to get worse, unfortunately. How does it feel for that to happen in October versus what it might have felt like if this had been April?
Yeah, I mean, like I had said, in April and May, we planned for a surge that really didn't materialize here, but that was very disruptive for our staff. And we've obviously had kind of this chronic broiling going on for the last 6 to 7 months as everywhere. And so now getting to the point where we see our surge is coming, we are really working hard to talk about resilience, to help our staff, to be as transparent as possible about where our numbers are and where things are going, and really trying to inform and communicate to the whole health system where we see things going.
Yeah. And do you want to add anything?
Yeah, I would say that now I think, we've learned a lot from the spring, and we don't have, I think everything was shut down in the spring as far as elective procedures. And now we've just tried to slow down to create some additional capacity. I think we're better prepared now. We know we have a little bit more of a measured response. We've built up 3 additional hospital medicine teams during the day and 1 additional team at night. We have some great collaboration going on with critical care. I think one of the changes we we learned kind of what patients we could keep out of the ICU a little bit better too. Early on, we, like others, were intubating patients when they required 6 liters nasal cannula. Now our hospital medicine service is certainly having multiple patients on high flow nasal cannula at very high levels. And so some of those things, I think it's been, unfortunately, none of us wanted to have experience in this field, but it has helped us overall.
Yeah. And are you, in terms of how you're dealing with it differently now than you might have 6 months ago? 6 months ago, we all basically cleared out the hospital, stopping basically all but emergency surgeries, and all ambulatory visits, went telemedicine. Is that what you're doing now, or is it 6 months later you have a sort of different response to creating capacity?
Yeah, I would say that our hospital describes that is we kind of went dark on all of our elective procedures in the spring, and now we just have placed a dimmer switch on those procedures. And I think that's been, we know that there's harm from people delaying procedures that they need. I don't think the word elective surgery is necessarily the right one. I think there are procedures that people need or care they need. And so we're hoping to preserve as much of that as possible while caring for the COVID-19 population as well.
Great. Andrew, anything to add on that?
Yeah, I would just say, I think that we did benefit from planning for a larger surge early last spring, and that's very much helping us now. All the communication that has been built up between all the teams and building of resources and infrastructure, we're very hopeful are going to help us through these coming weeks.
Yeah. I guess I'm struck, and actually maybe we'll bring George back if George is still on, because I love his thoughts on this as well. There he is. I'm struck, I look at those incredibly scary maps, and George showed us one of them, your state is as red as can be. And if this was March or April, we were hearing from people in New York who said, we have a 600 bed hospital and 500 patients have COVID and 250 patients in the ICU. And you're saying, we're up to 40 and 10. And, and we don't have any treatments that have been demonstrated to work to keep people out of the hospital when they're not that sick. We have some treatments that work once they're sick enough to need oxygen. So that feels like a disconnect to me. I would have expected you would be more surgy than what you're currently seeing. So can you just take a stab at what you think is going on? And are we just still early, and 2 weeks from now it would be much worse? Or do you think there's something fundamentally different? Then I'd love to hear George's thoughts. Go ahead, Andrew, why don't you start?
Yeah, I guess I would say, so really the epicenter of these outbreaks have been in the Northeast and the northern part of our state. And so the regional community hospitals up there are really quite full. They're running at 100% capacity, and we have reports of 20 to 30% of their patients are COVID positive. So we kind of are a feeder system for them. And as their capacity has grown, about 30% of our patients that we're accepting with COVID are coming as transfers. Mm-hmm. We also have built out our EICU infrastructure. We already had a large infrastructure for that with our regional hospitals. So that's something we've augmented in the last 6 months, and we are trying to help people have the care they need, even if we need to perform that with telehealth. Mm-hmm. But again, the capacity up north is quite high, so we expect that to be coming down towards us very soon.
Yeah. And anything to add on that?
Yeah, the only other thing I would add is I think we're much better at collaborating with our local Madison hospitals. I think our numbers would be much higher of COVID positive patient numbers if we weren't communicating a lot more frequently and a lot more deliberately with the hospitals in town.
Yeah. George, were you surprised by those numbers, and what's your take on it?
Yeah, I was surprised, but understand that this is the same kind of question about why were there fewer deaths, why were there fewer hospitalizations during the second wave? Younger population, big testing program for people who turn out to be asymptomatic, better job of protecting nursing homes, the whole idea of masks maybe cutting down inoculum size and having smaller, being smaller infectious doses. So there's lots of potential reasons, and I probably start by looking at age first. That could be pretty explanatory. MMWR 2 weeks ago had a couple of articles, I think, from Wisconsin that looked at age group, and there was a big surge in younger adult ages. But the interesting thing was that it was eventually followed by a surge in older patients as well. There's also a long table about excuses. which I restrained for myself from showing.
But do you think is the age thing, does it potentially mean that you're having sort of two phases of a surge? You hit the young people first, particularly in a college town like Madison, and then it's a couple weeks later that you hit the older people, and then you have your delay before hospitalizations in ICU?
Correct. Yeah, I think that, I mean, that's one, certainly, I think that's a pretty straightforward way to interpret it. Yeah.
Great. George, any questions you wanted to ask of Ann and Andrew? Oh, you want to know?
I think we're good. I think, it's great stuff.
I want to know the temperature there. What's the temperature today?
But yeah, what's the temperature today?
It's 47 degrees and wet.
Was that centigrade or Fahrenheit?
Up north, they had 5 or 6 inches of snow last weekend.
Yeah.
So people are coming indoors.
Coming indoors.
Yeah.
So, go ahead, George.
I just wanted to get your take on the state Supreme Court that banned the stay-at-home orders, correct? Or vacated them?
Yes. So I think there's been several court challenges. It seems like almost every order we've had has been challenged in the courts, including most recently the mask mandate and the 25% occupancy rate. I do think it's disappointing. I think in May, when the Supreme Court struck down the stay-at-home order, I think it kind of left us wondering. I think a lot of people were looking for guidance. It just all of a sudden was gone. What should we do? And it certainly hasn't helped our state manage this pandemic.
Too bad.
Yeah. Well, let me thank all three of you. Really appreciate hearing this, and hopefully it'll stay okay. There, it sounds bad, but not as bad as I actually expected it to be. But clearly, we're not at the end of it. And I hope you and your colleagues stay healthy and well. And good to see both of you. And thanks so much for joining us today. Really appreciate it. So let us move on to the next segment. And we're going to be talking about navigating risk, which is in many ways the central issue for all of us today. And so our speaker is Julia Marcus, who's associate professor in the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute. She's also an adjunct faculty member of the Fenway Institute. She's a frequent author in The Atlantic, where she's put together really a terrific set of articles on thinking about risk, how to measure it, how to understand it, and how to take appropriate action. And prior to COVID, like none of us were COVID people until 10 months ago, her expertise really was in thinking about behavioral change and risk assessment and management as it pertained to HIV. And so like many of us has pivoted, and also a bit of a homecoming for Julia since she got her PhD from Berkeley. So thank you so much for joining us. Really appreciate it.
Thanks a lot for having me.
My pleasure. So let's talk about the early days. So it has always struck me that life in March and April was hard because you couldn't do anything, but was actually quite easy because you couldn't do anything. And then May became easier because you could do some stuff, but much harder because everybody had to begin making about 1,000 decisions a day with imperfect information and some existential threat of doom. So as an expert in this way of thinking, I assume you saw this coming. So how did you process that in May, the kinds of issues that people are going to be faced with and some of the challenges they're going to have in navigating risk?
Yeah, I think you're absolutely right that in March and April, we had very clear, very binary messaging, which was really just to stay home. And I think that was easy for many people, but I think we also have to recognize it was not easy for a large chunk of the population that could not stay home. And we really saw that play out in terms of inequities and who became infected and who died. And we still see that happening. But you're also right that now we're in a much more challenging situation in a way because we're trying to figure out how to do this sustainably. I think, that initial message was 15 days to slow the spread. I mean, it seems mind-boggling now that we ever had a message that was around 15 days, right? And here we are saying, maybe we'll start to see some normalcy in 2021 if we're lucky, So it's really shifted our approach, or I think needs to shift our approach to start thinking about this much more sustainably. And so in May was when I started writing about this and suggesting that we need to take an approach that's less binary and really acknowledges these kind of trade-offs that happen when we make decisions about mitigating risk of transmission. We're always trading off something, and we have to figure out how to do that in a way that's sustainable, not just for individuals, but also on a societal level. There's all these questions about schools versus restaurants, and how do we not just in our everyday lives, but also as a society say, here's what we can do sustainably while keeping the risk of transmission at a low enough level that it's acceptable, whatever that may mean.
Yeah. We'll get back to that sort of binary issue, but let's maybe a little foundational knowledge. What do we know about how humans assess and process risk? We think we're going to get killed by the shark, and in fact, it's more dangerous driving to the beach or something, stuff like that. So this has been studied. Humans, I think, are not great at this. What do we know about how we do in this?
Yeah, you're right, there's a whole field of study about risk, how we think about risk, how we make decisions about risk. And that's a bit out of my area of expertise, but I will say, I think there are many factors that go into our everyday decision-making about risk that it's good to make explicit. So one might be what's happening with community spread. That's kind of the first one. Are we locally experiencing a surge, and that is going to affect the decisions we make. What is our personal vulnerability to a bad outcome from becoming infected or the people around us? I make different decisions about interaction with people who are much older, because their vulnerability is higher. And then what's the risk of the activity itself that we're thinking about engaging in? Is it indoors? Is it outdoors? What's the number of people? What's the duration? Are people wearing masks? All those same things we've been hearing about. And then I think what we don't often talk about explicitly is what are the benefits of this, of doing this thing I'm thinking about doing. Is there a mental health benefit of, seeing my family I haven't seen in a long time, or, sending my kid to school may confer some risk, but there might be some huge benefits there. So those are the things that I think become more difficult to talk about when we're really focused on infection prevention, but that's actually a huge factor in what drives decision-making about risk.
A couple of months ago, I was faced with one of these sort of sentinel decisions. My parents are 90 and 84 in Florida. My father's not doing well. And once I kind of recognized that we probably have another year of this, I thought it was quite likely that if I didn't figure out a way to visit them, I would probably never see them again. So tell me how you would have processed that set of decisions. Do I fly? Do I go? Once I go there, do I mask? Do I stay away? Do I hug them? All that kind of stuff. How would you have approached that from both an evidence standpoint and then kind of how do you approach it cognitively?
It sounds to me like you got to a point where you said, it's not acceptable to me to not see my parents. So then that it's going to happen, and then you can make decisions about how to do it as safely as possible. And so some things, are trade-offs, but we can handle them, right? Like there are many things that we can give up in our everyday lives for some amount of time, not indefinitely, but some amount of time, and it's acceptable. But a situation like that, and everyone is experiencing to some extent these situations where they really have to take some risk. And for some people, it's that they have to go to work because they need a paycheck to be able to eat. And for some people, it's a situation like what you're describing, where you really need to see a loved one while you can. And so then the question becomes, how can you do it as safely as possible? And I think our messaging and our policies need to be kind of framed from that perspective of acknowledging that people cannot eliminate risk from their lives. Society cannot eliminate risk. And so we have to give people guidance on how to do things as safely as possible. Just like the safer sex education, we don't say, just don't have sex. We give people the tools to protect themselves as much as they can.
Yeah. So maybe let's exit a little detour of to the world of HIV, because you have been thinking about sustainability and messaging for a long time. So what are the lessons that you and others have learned about this that are drawn from your experience with HIV?
Yeah, I first started thinking about this when I started to see people really shaming each other for taking risks. And this was starting to happen in April when people started to venture out of their houses a little more, and you started to see these photos and videos circulated online of people at the park without a mask, or whatever the situation was, and people being shamed for that and called selfish and reckless and stupid. And even from health professionals, the kind of messaging we've seen around masks, for example, has been, I think, oftentimes a bit moralistic. If you cared about people, you would do this, without really acknowledging some of the reasons why people might not be wearing a mask, which may be difficult to understand, but I think without trying to empathize with the people that we're we're trying to affect, whose health behavior we're trying to affect, we end up having very little impact because we're missing the boat on what's going on for them. And I think that's a lesson we learned in HIV. I mean, in the very early years of AIDS, if you look at the public health campaigns from that time, they were very moralistic about, if you have sex, you're a bad person, you deserve a bad reputation, and you're probably going to die, and very fear-based, shame-based messaging. And those did not really land well. And actually, they perpetuated stigma that till today we are still fighting in the HIV epidemic. It's still a barrier to ending this epidemic. And so watching that kind of play out, and the ways that sometimes that becomes codified in criminalization of exposure, we've seen that as well, and the ways that that plays out in terms of inequities with, if we looked at data, we're looking at data from New York City in terms of who was arrested for social distancing violations in March and April, it was almost exclusively Black people. So all of these same patterns played out in HIV over a much longer period of time. And it's like they got compressed in COVID and played out over the course of just a few months. And so seeing that really made me want to provide a framework of what has helped guide HIV prevention toward a more humane response, which is more of a harm reduction framework as opposed to this kind of abstinence only model that it frames everything as a personal choice and a personal failure. If you have risky sex, you're a bad person. No, it's actually, what is the unmet need here? Usually when there's some kind of risk behavior, it reflects an unmet need. And what can we do to help meet that need? Is it a basic survival need? I mean, we need to be giving people paid leave so they can stay home from work when they're sick or even waiting for a test. Or is it a psychological need? We actually do need to enjoy our lives and have fun and have our kids at the playground, and just these sort of basic things that when you move past March and April and you get into this long-term situation, you really have to be thinking about maintaining resilience in society and giving people ways that they can enjoy their lives in low-risk ways so that they can be vigilant in those higher risk settings where it really matters.
So let me push back a little bit on the HIV analogy. And you're talking about, in terms of safe sex, you're talking about consenting adults generally who are making a choice that the benefits of this outweigh any downsides, and then can engage in protection that each one can sort of see to some extent. I guess you can't see if the other one's taking a medicine, but you can see if they're wearing a condom, for example. Whereas here, when I go into the Safeway or the Walgreens, I'm surrounded by people who may or may not, or I get on an airplane to visit my parents, people may or may not be wearing masks. Some of them I guess I'd love to be empathetic, but I'm not that much in that it doesn't seem like it's all that onerous to do. Some of them are doing it because of a political philosophy that happens not to be mine, which is in some ways irrelevant, but makes me a little less empathetic. And we can't tell who they are in terms of whether they're infectious because of the asymptomatic spread thing. So I'm struggling. I sort of the general idea of harm reduction and being more empathetic may work better, sort of just practically, than being moralistic and nasty about it. But in terms of whether the analogy is right, it feels like there's some fundamental differences here.
Right. So I think you're right that there's a fundamental difference in the sense that we're talking about two very different viruses that are transmitted in different ways. And the coronavirus is much more, the risk has the potential to be much more explosive. So HIV can also be transmitted beyond the partner that's in front of you, but the time scale is so different, and the potential for a super spreader event is not there, right? So, and yes, when you go to the grocery store, you are not necessarily, you're not consenting. It's not a consensual act to have somebody not wearing a mask around you.
Yeah.
And so I think that is actually something that can guide decisions about where we want to require certain things. I mean, I think in the HIV response, we have learned that enforcement is something, and in general in public health, enforcement is something we want to use as a last resort. But I think in situations where we're talking about indoor environments where people don't have a choice to be there, particularly the people who work there, we have to ensure that they are protected. And we have to do it in a way where we're really being conscious about some of the challenges that come up around enforcement and what kind of precedents we're setting with mandates. I think they should be used carefully, but I think that what you're saying is important, that the difference between these situations is there for sure.
Yeah. And so, thank you. And so what do we know about mandates from HIV or from other illnesses, this always comes up. If people are not going to do this thing voluntarily, we need to mandate it, and that has sort of certain chances of working and not working and causing backlashes. Or talk about mandates, but also then other strategies, incentives, influencers. Who's an influencer, and how effective are they in changing behavior? What do we know about changing the way 350 million people or billions of people around the world think about something like this?
Yeah, I mean, the example from HIV is criminalization of exposure. So if you, in many states, over 30 states, if you have sex with somebody and you're HIV positive and you don't tell them that you're HIV positive, that is a criminal act. And there are variations on that. And in some cases, it's actually a criminal act, even if you are on medication and you're virally suppressed and you cannot transmit the virus. And so many of these laws are actually unscientific in that sense. And it turns out they don't deter behavior, right? They don't change people's risk behavior. And in fact, what they do is they deter people from getting tested. We've seen the ways that these laws can drive people away from care. And I think that that's kind of a common thread in, if you look at substance use as well. Criminalizing substance use is not an effective strategy. And so applying that here, I think we can, we can think about parties, let's say, and the ways that police have been brought in to deal with social distancing violations, like large indoor gatherings. So, there does need to be some response, but I think we have to be careful about bringing in the police for two reasons. One is it's not actually feasible to unleash cops and have them control the 350 million people you're talking about, right? And the kinds of harms we would see from that are enormous. And secondly, we have to give people safer alternatives. And I think that's kind of the harm reduction framework. What we can take from there is, you can't, if we think about social contact as an unmet need, and of course do people need to be having large indoor parties right now? No, that's not a need, but yes, humans need to interact. And so how can we support them in lower risk ways of doing that? And we've seen some examples from, let's say, college campuses where, I think in general, they have not taken a harm reduction approach, but some have opened up outdoor spaces and made them really appealing for students with Adirondack chairs and fire pits, and sending this message that they understand that students need to socialize and they're providing a safer space to do it. And we've seen some examples of that in cities as well, with parking lots turned into beer gardens in places where people lack private outdoor space. And so that's another key point here too, is that not everybody has a yard where they can gather more safely with people. So we have to ensure that those lower risk opportunities are there.
So tell us, I'm sure you get asked constantly about schools, and I'm not talking about colleges now, but elementary, middle school, where you talk about harm reduction and you talk about the trade-offs of really balancing risk. And there's no debate that keeping kids out of school carries a risk probably to both education and their life and to health. And yet we know the schools are not risk-free from a COVID standpoint. So how do you process that differently than the average layperson who's trying to think about their kid?
Schools are complicated, like everything else in this, and I think we have more to learn about what's happening in schools in terms of risk of transmission actually in schools that have implemented mitigation strategies. But like everything else, there are huge trade-offs, and I think they are really particularly salient in the context of schools. That keeping kids out of schools, I mean, for example, here in Boston, schools went fully remote today. So there were high needs kids who were in-person learning yesterday, and we're talking about severely disabled kids who don't speak English, kids who are involved in child protection services, and those kids are no longer in school today. And so, I don't know how we can make decisions as a society about trade-offs here, but to me, it seems that they are enormous, and that we need to be really finding a way to make decisions that prioritize, kids' health, teachers' health, the families. I don't have a good answer for you on how to navigate this, just to say that those trade-offs need to be talked about explicitly.
Yeah, that's an incredibly hard question. I struggle with it all the time. You've talked a little bit about and written about the fallacies of sort of an all or nothing risk assessment. So take us through that in a little bit more detail, because I think it's another part of COVID that's particularly tough. You're you're not just assessing your risk from this activity, I guess, against the pleasure you get from it and the importance of it in your life, but you're then assessing the risk to third parties, if you get it, who may be older and immunocompromised, who may be people you know and care deeply about, and may be strangers. So in some ways, it's a test of our generosity and kind of beneficence. I don't know any human being who can like process that and not drive themselves completely crazy as they're trying to decide whether to get a haircut, which is really kind of what we're talking about, like 100 decisions a day. Are you going to go through that mental gymnastics to try to sort that out? So how do you do this?
Yeah, I mean, I think your point is well made that it's crazy making. And I think it's particularly crazy making when we aren't really getting a whole lot of support from our government and to our federal government in terms of helping people stay home, giving people safer alternatives, giving people really good guidance with a national unified public health voice. You know, we're kind of lacking. It's like our parent left the room and we're trying to figure this out on our own. And I think another way that it's a little bit crazy making is some of the dissonance we see in policies that are being enacted, you know, that there are in some places more restrictions on playgrounds than there are on indoor dining, you know, that kind of thing or, you know, my kid being in a paid childcare at his school, doing remote learning at the school. And, you know, I'm trying to make sense of that every day, you know, just these things that don't quite make sense. And if you really think about it, you're like, okay, I guess I see how that decision was made, but it drives you a little nuts. So yeah, I think every person needs to figure out kind of a framework for making these decisions themselves. And unfortunately, we're kind of on our own. And I was hoping that we would see our really trusted CDC in, you know, guiding us through this. But unfortunately, given the political climate, that's just not what happened.
And what do we know about influencers? So if you're trying to change the behavior, I keep thinking like to change the behavior of a 25-year-old, you need like the equivalent of Bruce Springsteen and Barbara Streisand, but you know, I'm just aging myself. I have no idea who that is for a 25-year-old. But you know, is it need to be celebrities and sports stars and Instagram heroes? Or how important is political leadership? How important is scientific leadership in getting people to do, quote, the right thing? Obviously, as we've said, the right thing is that has sort of a moral overtone as well. But what do we know about how you get people to change behavior?
Yeah, I mean, it's a great question. I think one of the core public health principles for you know, any kind of public health effort is community engagement. And this is one of the reasons. People are not always going to listen to public health professionals and what we have to say. And we have to find people who they will listen to, and it's often members of their own communities. And it may look very non-traditional. So what came to mind when you were asking that question was two things. One is our president saying that he would not wear a mask. So that he's an influencer, a huge influencer, right? And that I think really changed the course in some ways of, you know, how things played out with masks and politicization and opposition to them. And we always see resistance with any new public health intervention, but the politicization we've seen around masks, I think, is much more unprecedented than, let's say, resistance to seatbelts that kind of died down after a while. And one thing that you know, really struck me around masks was a tweet from Liz Cheney of her father, Dick Cheney, wearing a mask. And she said, #real men wear masks. And it was so fascinating to me because obviously Dick Cheney is a complicated character, but I think that tweet probably saved lives because it will reach people who traditional public health professionals will not reach. And we need that. And we need it, I think, especially for young people who, I don't know where they're getting their messaging right now, but we are asking so much of young people who are at very little risk, not zero risk by any means, but very little risk of a bad outcome from this virus. And if you take college students, we're asking on many college campuses, students to stay 6 feet apart at all times from everyone. And it's a huge ask for, you know, a risk that's very distal to them. So we need to find a way to help engage people in making different decisions and also recognize that what we're asking is a lot.
You've talked and now written about pandemic fatigue. First of all, how long does it take for that to set in? And then how does it change the nature of the decision making? You know, I mean, the risk of dying of this thing has gone down as time has gone on. So even just without any fatigue, that would change somebody's risk-benefit calculus a little bit. But on top of it, you now have, we're already 8 months into it. We have a minimum of 6 months more, probably more like a year, if that. So how does that change the way people should be weighing the risks and benefits and probabilities, given, how long a time course we're talking about?
Yeah, I mean, I think pandemic fatigue, we're all feeling a sense of exhaustion with this, and we're not robots. We are humans who need to see each other. And as this goes on, it becomes more and more exhausting to be vigilant on an everyday basis and to make these, the 100 decisions we make every day that you were talking about. And I think it's something we need to recognize too, from a public health, kind of a population perspective, that people are exhausted. And I think we need to give them something and give them a sense of ease in some places. And I wish that we had seen more of that in the summer, actually. And of course, it depends where you live. And here I'm coming from the perspective of, it's getting colder. And I wish that we had seen more just outdoor activity. And there was some, but there are still places where, playgrounds just opened in San Francisco about a week ago, and parks were shut down in Hawaii until about a week ago. So I think we didn't take full advantage of lower risk spaces to give people a sense of ease and allow them to relax a little bit so that they could sustain that vigilance. And so I think fatigue is something that we should incorporate into our decision making as public health professionals and policymakers. And of course, it's something that people are experiencing on an individual level as well.
So incorporating decision making, meaning that here is a standard and a restriction that may make some sense in terms of the risk-benefit calculus today, but when you sort of think about it over the next 8 to 10 months, it just will not work. And the backlash against it will be worse than if you made it a little bit more lenient today, but that was sustainable. Is that the way you think this through?
Exactly. I mean, I think we need to, it was different in March. We were able to really come together for a short period of time. Some proportion of the population was able to stay home. And there was a sense of collective action, and we are not there now. and so we have to recognize that and ask, I think, as little as possible, and really try to focus our efforts on the highest risk settings. And actually, that is what transmission dynamics tell us to do. Most people do not transmit the virus, and there's a small proportion of people that transmit quite a lot. And so we want to focus on those settings, those high risk settings that turn into super spreader events, that turn into clusters, and try to address those and relax, I think, a little bit on the lower risk settings where people they need some ease, I think.
Okay. How does all of this change? Let's say it's January 1st and the FDA has just approved a vaccine. And we know that now, rather than some amorphous end date, and we think the vaccine is going to be 70 or 80% effective. So rather than some amorphous end date, we're looking at least at some probability that we've got 3 to 6 more months of the current situation. We'll end up in some new normal that's probably not 2019, but it's not now. And people are beginning to anticipate that, and maybe it gets them excited, and now you're going to be, it's sort of the person who gets the last person to get killed in a war. Now you're going to feel really badly if you get infected like the day before the vaccine comes out, particularly if you have a bad outcome. So how do you process the changing dynamics as we get closer to a quote end, even though, tempered end, whatever that looks like?
Yeah, I think the tempered end is important to talk about, because I think there's this perception that we'll have a vaccine and then the next day we can, go back to living our lives. But, I work on pre-exposure prophylaxis for HIV, which is very effective in preventing HIV, and yet we still see very little evidence of population impact. So we have a very effective intervention, but it's all about implementation and making sure that it gets to the people who need it, and making sure that there's equity in that. And, so there's a lot of questions, I think, about vaccine implementation and scale up that will affect that timeline. And so I would hope that we continue to think about sustainability, and that we don't get kind of duped into thinking, oh great, there's a vaccine, let's just throw it all to the wind.
I mean, you could say it's almost inevitable that as soon as there's a vaccine that's approved, again, assuming the FDA process is evidence-based and normal, quote unquote, that people will begin to take a deep breath, say, I know it's not tomorrow, but 3 months from now, my life will return to normal. And therefore, maybe that helps in a short term. I can buck up to make it for 3 months, but then be vastly disappointed that it's not quite normal when they get there.
Yeah, I think the public health messaging around that is going to be essential.
Yeah. If you're willing to take us through some of your own decisions about, do you go to restaurants? I don't know if you have kids, but the school issue, we've had a few questions about, would you fly today? All those kinds of things.
Sure. Although, of course, as I was saying, these decisions are multifactorial. So I wouldn't want my decisions to be, adopted by anyone else necessarily. I don't go to restaurants, although I think I would go to an outdoor restaurant. I just haven't done it. I do go to parks. I go to playgrounds. I do have kids. They're 3 and 6. The 3-year-old is in daycare, and the 6-year-old is in a hybrid situation, but sort of a Tetris kind of childcare situation. Would I fly? I mean, your personal situation you described, where you took a trip for a reason that was very important to you, I would do that.
Mm-hmm.
I wouldn't fly to Vegas for the weekend just to have a good time. Yeah.
Great. And you kind of hinted at this, but I just love a little more detail. What are the lessons from HIV about the vaccine? So let's say the vaccine is out there, we're trying to implement it. We have 50% of people on surveys today saying, I'm not going to get it. It's gotten politicized. Let's assume again that it's clearly been demonstrated to work and be safe and been approved with a process that we think is credible. And yet, we know from other interventions and other infections, the uptake is not perfect and people have to be convinced, and their mandates have problems. So what can we learn from HIV that will help us as we think this through?
Yeah, I think all those same principles that I've been talking about really apply here, which is that we have to meet people where they are in terms of what their concerns are, what their hesitation is. And we see this from other areas. I mean, we don't have an HIV vaccine, but other areas of vaccine research have found that if you really try to empathize with what people's reasoning is around vaccines, that's going to have a better impact in terms of building their trust and getting them on board. And so I think community engagement and building trust, and also I'm not as concerned. I mean, I think that all of this is important, but the hesitancy that we're hearing now, people saying that they wouldn't take a vaccine, I don't think that's necessarily going to translate to, 6 months from now, when we're in a potentially very different political climate. I think we have to be careful around the messaging, but I am not panicked about, nobody accepting this vaccine. I think another thing that we've learned from HIV is the importance of equity when we implement anything. So for PrEP, which I work on, we've seen limited population impact because it's reaching the people, it's not reaching the people who need it most. It's used least by those who need it most. And we don't want to see that playing out with this vaccine. So we have to ensure that we're engaging communities, particularly marginalized communities, who may have more distrust of the healthcare system, and engaging them in every step of the process so that they're not left behind.
And have we learned, HIV, we've been at this now for a long time. Have we learned anything about how to do that?
I think the community engagement piece is the most important thing. So we have to be bringing in community members and leaders as we develop a vaccine, as we implement it, as we message about it. It has to be community engaged, or it's going to fall flat.
So maybe my last question, as you think about the next year, what are the parts of it that you're hopeful about? What are the parts of it that you think can go off the rails if we're not careful? It's going to be probably as, if not more complex than the last year, which is hard to believe.
Yeah, again, coming from a Northeast perspective, less so for all of you in the Bay Area, I worry about the winter. It's a long period of time where we really spend very little time outdoors. And I think, in terms of the epidemiology of this virus, the outdoors has been such a key prevention opportunity. And I worry about not having that. And it's already coming into our personal decisions here about, do we see our elderly relatives indoors and how do we do that, which we haven't done since early March. So I think it's going to be a really challenging time, but I'm hopeful that we will get through this with some amount of social cohesion, especially if, depending on the election outcome. We'll see how it all plays out.
Yeah, yeah. Well, Julie, thank you so much for your leadership in this. I've learned a ton from reading your work and hearing you interview in a few other places, and this has been really helpful and instructive. It's clear that we needed to learn this science as well. That we've, as I wrote the other day on Twitter, I mean, I feel like I've gotten a PhD in COVID this year, and there's a big piece of it that relates to how you think about risk and managing it and assessing it and applying it to your life. And I think you've done more to educate the public on that than pretty much anyone else. So thank you for being with us today, and really appreciate it. Keep up the great work and stay safe.
Thank you so much. You too.
Yeah. So thank you all for joining us today. I hope you enjoyed it and learned as much as I did. As always, thanks to our speakers and production team. You see them listed here, who put this on flawlessly every week. This will get posted on YouTube tonight at about 7:30. I will tweet out a brief summary as well as the address. We've gone to every other week COVID, as the rest of medicine still is out there and lots of stuff going on. So next week will be a regular medical grand rounds, and then we'll be back the week after. And I suspect we'll be talking probably about the results of the presidential election, which, believe it or not, will have been done, as well as maybe vaccines and where we are in that process. So tune back in and we'll see where we are. But thank you, and stay safe, and see you next week. Thanks. Be well.